Hello, hello. Welcome everyone to another case of a virtual morning report. My name is Youssef. I'm a resident at Emory in Atlanta, Georgia, and CP Solvers member. So glad to be having this session with you all. We started the series a few months ago where we approach management rather than diagnosis. We love for these sessions to be as interactive as can be. So we would love it if you share your screens if you're able to put your answers in the chat and discuss with us. The session today is with David. David, do you want to introduce yourself?
Hi everyone. I have two screens because my laptop audio is not too good, so I'm with my phone at the same time. But well, I'm also an internal medicine resident from Madrid, Spain, and very happy to accompany Youssef in this session.
Yeah, thank you, David. I'm excited for the session. So compliments of Sarah. We're gonna have a small icebreaker right before we start. We would love if you would. We're gonna assign you all to breakout rooms. The question for today is if you could shop from one store for the rest of your life, what would that store be? And if you can just share one fact about yourself and where you're calling from. I'm gonna give this just a few minutes and then we can start our session. So David, do you want to get us started with the case?
Yeah, perfect. So when you're right, the chief concern is lower extremity edema. This is a 50-year-old male with 1 week of worsening bilateral low extremity edema. He does that in the past 2 days. He also has some abdominal discomfort and nausea, but no abdominal pain. He denies fever, night sweats, or weight loss, and he also endorses mild dyspnea on exertion and orthopnea. No cough, no chest pain, and no palpitations. Okay, can repeat a little bit. It's a 55-year-old male with 1 week of worsening bilateral lower extremity edema that in the past 2 days also endorses abdominal discomfort and nausea, but no abdominal pain, no fever, no night sweats, and no palpitations. The past medical history is relevant for type 2 diabetes on metformin, hypertension on losartan, obesity grade 3, and low back pain on ibuprofen. He's a smoker, 5 cigarettes a day. He drinks 2-4 beers on weekends, and he told us that he hasn't seen a doctor in the past 8 years. I will keep up with the physical exam. Temperature was 36.9 degrees Celsius. Blood pressure 98/56. Heart rate 94. SpO2 93 on movement. The cardiovascular exam was a regular rhythm, no murmurs. Pulmonary exam was without crackles or wheezing. There was diminished breath sounds in bases. The abdomen was distended, soft, distended, soft, non-tender, and without a rebound or guarding. There was no palpable hepatomegaly or splenomegaly. The extremities, there was 3+ pitting edema up to knees in both legs, and there were signs of venous insufficiency, but no signs of DVT. In the skin, there was no rashes, and we could see spider angiomata in the chest. So I will pass the mic to Youssef to ask you some questions.
Thank you, David, for presenting the case. Just polling the crowd, what thoughts are you having about the differential? I see Mu'taz, Reshma, or Laura. Are any of you in a good place to share with us your answers?
I can go. Hey, everybody. So good to see you. I unfortunately quit my breakout room prematurely. It was a mistake, but I'm so happy to be back here. So I think one characteristic of edema is that it can be classic to the type of organ involved. For example, if it's cardiac edema, the legs get involved first. The patient presents with pedal edema more than ascites or facial puffiness. But in case of hepatic involvement causing the edema, the presentation is more of ascites, and then comes the leg involvement, and then goes the face. And in case of like renal involvement, the facial tissues, the facial puffiness is how it presents. So here, I think it could be either a cardiac or a hepatic cause of edema rather than a renal. But I think cardiac can also cause hepatic edema by causing, congestion, cardiac hepatitis, and I'm not sure what cardiac cirrhosis. Yeah, cardiac cirrhosis. I think the classic appearance is something called nutmeg liver because of the congestion in the liver. So I think cardiac cirrhosis could cause a combination of both hepatic and cardiac edema. And yeah, so I would definitely rule out renal edema, but it's still like good to get the labs done before we take anything off the plates, though.
I love the answer, Reshma. We love having you on this platform. Thank you for always joining. I love the answer as well. You said cardiac, hepatic, and renal, which is the standard schema that we have for edema. Thinking from a likelihood perspective or from a sensitivity and specificity perspective, if I'm just asking the crowd and not specifically Reshma, what is one test or one thing that if you see, I can say, oh, this is definitely related to the liver? Or what points you towards the liver rather than any other etiology? Is there any specific test or exam finding that you think of? Renato said jaundice. Laura said spider angiomatas. Wonderful. Thrombocytopenia is pretty sensitive. Pinya is going for early satiety and hepatomegaly. So wonderful answers. So there was a paper in the Rational Clinical Exam, which is a series that focuses on diagnosis. And the elements that have the highest likelihood ratio positive, that points us towards ascites or towards cirrhosis is ascites, which has a likelihood ratio positive of 7.2. Spider nevi or spider angiomata have a likelihood ratio of 4.3, and a platelet count that is less than 160 or less than 110 have a likelihood ratio positive of 6 and 9, which is relatively positive. All the other things that you said definitely point to cirrhosis. All of these exam findings, but the likelihood ratio is actually not that high. So you can't definitively say that this patient has cirrhosis if you see hepatomegaly. The likelihood ratio is 2.4, which is high, but not definitive per se. So there are, in our minds, when we see cirrhosis in the hospital, we think of somebody who has jaundice, who has edema, and has frank cirrhosis. But in reality, in the clinic setting, cirrhosis can be very subtle. And physicians have been trying to develop tests that detect cirrhosis as early as possible. So to give you some tools that you can use in the clinic, so there are things to think of, like the FIB-4 score. That's a score that was developed that incorporates the AST to ALT ratio. That's initially developed for hepatitis, but later on validated for NASH cirrhosis, for example. There's the Bonassini discriminant score. That's a paper that incorporated also AST and ALT that also has a likelihood ratio that's close to a 9 that you can use. And then there are things like imaging. So there's this new imaging called elastography, or a fibroelastogram, which is a way to measure the stiffness of the liver, is one way to screen for fibrosis and cirrhosis. And then other things include imaging like ultrasound, CT, or elastography. So the first teaching point I wanted to bring to your attention is that cirrhosis can be subtle and will not always be immediately detected on our exam. Throwing it back to you, David.
Okay, so we're seeing some basic labs at this moment. The CBC leukocyte count was 9,000. Hemoglobin was 13.4, and platelets were 105,000. The BMP glucose was 128, sodium 132, potassium 4.6, BUN 48, creatinine 2.7, total proteins 5.7, albumin 3.2, AST 55, ALT 40, GD 215, ALPHOS 98, and LDH 201. So now we have more information, and we think we can do a breakout room to see what you think, what is happening to this patient, and what you suspect.
Welcome back, everyone. I'm gonna choose someone from breakout room 1 to give us just their initial thoughts, and if they can give us one way that cirrhosis can, or like decompensate. So maybe Gustavo, if you're able to unmute, or
Hey, Youssef, we didn't hear from Gustavo. I can fill in for the group though. Ascites is one way that cirrhosis can decompensate, which comes to mind because this patient had abdominal discomfort.
yeah, thank you. And then can someone from group 2 give us another idea of how can cirrhosis decompensate, for example? I think group 2 was, let's see, it was Ayan, David, Kirsten, Mariana, Sarah, and Laura. If not, that's okay.
Get it, hepatic encephalopathy. I guess that would be late stage. I don't know what would be in between.
We're at 2. Can somebody from group 3 share their thoughts? Group T is Aisha, Muataz, Rishma, Ricardo, Sohel, Kushal, Mahdi.
Hello, Yusuf, how are you? I think the cirrhosis can be decompensated into AKI by way of infection can cause spontaneous bacterial peritonitis that can be a cause of acute tubular injury or as a sign of redistributive problem for the generalized vasodilation with hepatorenal syndrome that can cause some renal vasoconstriction causing AKI in this issue.
Yeah, thank you so much. David, back to you.
Okay.
I think my audio is having some problems, but can you hear me now?
Yes.
Okay. So the types of decompensation in cirrhosis are many, but I think we can speak of them in starting from two key pathophysiology features that are circulatory dysfunction with RAS activation and systemic inflammation. Cirrhosis is a state of systemic inflammation via plenty of ways, but microbial gut microbial translocation is one of them. And there are a lot of decomposition. Some were mentioned. Ascites and edema is I think probably the more frequent. And in every decomposition, we have to think not also in the syndrome itself, but also in the triggers. Triggers for ascites or volume overload are drugs or dietetic changes, infections, including SBP and other events that patients with cirrhosis can have, such as portal thrombosis. In the workup, we should ask for labs, including liver and renal function, and serum and urine electrolytes that we'll talk about it later. And we should do a diagnostic paracentesis, and also if there's concern for portal vein thrombosis, a CT or a US Doppler. Related to ascites, SBP is another way to decompensate spontaneous bacterial peritonitis. Then we'll talk about it more later, but is not a clinical diagnosis, but a laboratory one that is defined with more or equal to 250 PMNs in the acidic fluid plus minus bacteria in the culture. Later, not every AKI in cirrhosis is a way of properly a way of decomposition, but HRS is a specific complication of cirrhosis, a specific type of pre-renal AKI, and has a criteria specific that we'll talk later. But I want to center now a bit on triggers. Triggers for AKI are infections, SVT, UTI, pneumonia are the most frequent in these patients. Also GI bleed, because of the probability of being depleted, volume depleted. Also, large volume paracentesis could induce dysfunction in the circulatory system, leading to RAS activation that could induce HRS, and there are many others triggers. No, variceal GI bleeding, esophageal or gastric is another way. Hepatic encephalopathy was also mentioned, and this is a clinical diagnosis. Not there are no specific labs to diagnose this kind of encephalopathy, and ammonia levels are not recommended, as they do not correlate with the levels of hepatic encephalopathy, but it's not bad to consider checking if in an encephalopathic patient without known liver disease or as a prognostic tool in a patient with acute liver failure. Well, there are many other ways. Hydrothorax, there is a transudate pleural effusion that tends to be more in the right side, which are complete criteria for transudate, and you have to exclude other causes to diagnose it, and usually appears in the presence of ascites, but in almost 20% it can appear in patients without ascites. So, for example, in this patient with diminished raised breath sound, one possibility is hepatic hydrothorax associated with or not with ascites, but also we have to take other possibilities, such as, for example, the elevation of both diaphragms in a patient with cirrhosis can make the breath sounds to be diminished at the base. And there are other complications that I will not address, but hyponatremia, cirrhotic cardiomyopathy, portopulmonary syndrome, hepatopulmonary syndrome, and hepatoadrenal syndrome, that is a kind of adrenal insufficiency specific to cirrhosis, are other ways of decompensating. So after reviewing this kind of decompensation in patients with cirrhosis, Yusuf will tell you more data in the case.
Thank you, David. So like to recap, the 5 like most common ones are, like David said, are ascites, SBP, hepatorenal syndrome, variceal GI bleed, and hepatic encephalopathy. And any one of these can count as a decompensation. Taking us back to the case, the patient's urinalysis was bland, was normal, but the urine electrolytes were notable for a sodium of 8, the potassium was 14, the creatinine was 89, the urine. The chest x-ray showed no consolidations, no pleural effusions, no cardiomegaly. And the abdominal ultrasound with Doppler showed ascites and no signs of portal vein thrombosis. At this juncture of the case, I wanted to send a poll to everyone who is in this meeting. I'm going to launch it now. The question is, hypothetically, in different patients, who needs a paracentesis? So I just started the poll. So if a patient with cirrhosis admitted for encephalopathy, should the team get a paracentesis? Second question, if the patient with cirrhosis admitted for volume overload, should they do that? And then the other questions are GI bleed. And the fourth scenario is acute kidney injury. I'm absolutely loving these answers, and it helps me a lot to guide the teaching today. So the first vote was hepatic encephalopathy. The answers are 50-50. At volume overload, it's 75% yes, 25% no. The GI bleed, 30% said yes, 70% said no. And then for AKI, it's about 50-50 as well. So the trick here is that the American Association of Liver Disease recommends paracentesis for every single patient with cirrhosis who gets admitted to the hospital emergency, regardless of the etiology for the admission. And this is tricky because traditionally SBP is thought as a syndrome of pain, vomiting, nausea, fever, tender abdomen. However, studies have shown that a patient with SBP can have none of these symptoms and still have SBP. Not only that, there were studies that compared a paracentesis within the first day and within 48 hours after admission to 72 hours within admission for patients with either hepatic encephalopathy or AKI. And the patients who got delayed paracentesis had a higher mortality rate. And there are even studies that show that the delay of paracentesis has an increased mortality for every hour that is delayed as well. Which brings us to the teaching point is that spontaneous bacterial peritonitis is a serologic diagnosis, and it's not a diagnosis of physical exam or history, which is very interesting to me, is that you cannot evaluate if a patient has SBP on physical exam or history. It's essentially the paracentesis which will let you know, inform you. Okay, and now taking us to the next teaching point, or the next data we have, is that a paracentesis was performed and the total protein was 3.1. The albumin was 1.6. The leukocytes were 460. And the PMNs were 385. The culture from that fluid, from the acidic fluid, was negative, actually. I was wondering if you could help me interpret these results. Ricardo, I don't know if you're able to unmute.
Hi. Well, actually, I would prefer like someone else because like I'm like very not expert in the serum albumin. Like I have always had like very hard time during like my step study. I just remember like if it was like lower than 1.1, I think it was labor, but like yeah, I would prefer like someone else. Sorry.
No, you're doing great. You actually mentioned it in the chat. So SAG is greater than 1.1. And the way I want you to think of the SAG as a on-off switch. SAG high, portal hypertension. SAG low, no portal hypertension. And that's all you need to know about the SAG. And I want you to keep that in your memory. And the other thing we have is the protein. Is anyone able to help me interpret the protein?
Hey, Youssef, I think the cutoff is 2.5 for poor versus rich, where if it's less than 2.5, you're worried they're having severe protein loss from nephrotic syndrome and they're not getting a lot of protein in. And then if it's greater than 2.5, it's pretty much everything else. And you can think of it kind of like an exudative effusion, like what can cause kind of leak inside, outside of a vessel.
I love it. Thank you, Andrew. And I see confirmation from the Yasmin and Laura. So the way I want you to think of the protein is the way Andrew said. If you have a low protein, I think either there's a production issue or there's loss in the urine. So if the protein is less than 2.5, that means either the liver is not producing them, so you think of cirrhosis, or you're losing protein in the kidneys. So it's nephrotic syndrome, for example. So, and then all the other etiologies should not have a low protein because you're not having a defect in protein production, for example, or loss. So far we had the SAG, portal hypertension, yes, no question. And then the either low protein ascites or high protein ascites, and the low protein ascites are cirrhosis and nephrotic syndrome. And then Shema said in the chat that a cutoff of 250 leukocytes, granulocytes points to SBP. And I think you all has been hammered home with all of the education that we've had so far. David, back to you.
Okay, so in this case, what is more concerning for me about the labs is the creatinine. It's true that we don't have the baseline creatinine of this patient, and we think, well, the patient told us that he hasn't visited a doctor in the past 8 years, but in this case, one of the main questions you have to ask is if the patient has an AKI, of course, and if this AKI could accomplish criteria for HRS. Most AKIs in a patient with cirrhosis are not AKS, and HRS, sorry, and HRS is an exclusion diagnosis. HRS can be divided in two types. In the past years, there was called type 1 HRS, that now is called HRS AKI. This is seen mostly in the inpatients and needs aggressive treatment because the mortality is so high. The management is mostly done in the ICU. And there are different stages, 1A, 1B, 2 or 3, depending on the creatinine from the baseline. And there's the type 2, what is now called HRS and AKI, NAKI, and can be divided also in two groups that are in the advanced kidney disease, that is a bump in the creatinine that has been for less than 3 months, and chronic kidney disease that has been for more than 3 months. You have to think in this type of AKI in patients with mostly in clinic, and it doesn't need so much aggressive treatment. The diagnosis of AKI, as I said, has to rule out other causes, and I wanted to review first some of the specific causes of AKI that could appear also in cirrhosis. Perirenal can be from congestive nephropathy, from circulatory dysfunction from large volume paracentesis, and also from shock, from GI bleed, diarrhea, from excess of laxatives is another common cause of AKI in these patients, and also the hypovolemia from the excess of diuretics is another frequent cause. In the intrarenal bucket, there is the possibility, of course, of an ischemic ATN from perirenal causes or from sepsis, such as in every other patient. There are some of the meds that are used in patients with cirrhosis, such as spironolactone, NSAIDs. Remember that this patient had low back pain and was taken ibuprofen. Could also induce an toxic ATN. Well, NSAIDs could induce perirenal AKI, but that prolongs the glucose and ATN. Also, the contrast, although the contrast associated nephropathy is not is controverted, but in this patient, contrast, intravenous contrast can cause a bump in the creatinine that could be difficult to interpret and to differentiate from an AKI. There's also this entity called cholemic tubulopathy from in patients with hyperbilirubinemia, but doesn't tend to cause too much AKI and has to be prolonged hyperbilirubinemia. And And there are also some specific causes linked to pathologies such as IgA nephropathy, the glomerulonephritis associated with hepatic HCV or HBV, and the viral hepatitis. But for diagnosing an HRS, does anyone know which are the criteria that should be requested for this diagnosis? And if anyone can put it in the chat, or if anyone want to say it.
I think Yaz had put it in the chat just a little bit earlier. I don't know, Yaz, if you're able to unmute or not.
For me? Oh, yeah, I did put the criteria for, if that's what you're asking, because I think oh, thank you. My sound was like failing right now. But the criteria, I don't remember because there are many, but the main criteria is cirrhosis plus ascites and elevation of creatinine of 0.3 in less than 48 hours or 1.5 in 7 days from the baseline. And the other one was the urine output of less than 0.5 in 6 hours and no improvement of the patient state with albumin effusions for more than 2 consecutive days. But I know that there are more. I'm not sure.
Yeah, well, those are perfect. And the patient should have absence of shock, also absence of current or recent use of nephrotoxics like NSAIDs or contrast, and there shouldn't be signs of structural kidney injury. Proteinuria less than 500, absence of hematuria more than 50 red blood cells very high IPF, and a normal renal US. And one of the key questions was the one you mentioned, that the patient should be without a response to the diuretics withdrawal, and with 2 days albumin infusion. This is somewhere called the albumin challenge, that has to be at 1 gram per kilogram per day for 2 days, with a maximum dose of 100 grams per day. So if a patient accomplishes this criteria after holding diuretics and stopping nephrotoxics, the HRS could be diagnosed. There's also some information that in the urine lights that could point towards an HRS or a prerenal AKI in cirrhosis, but they don't rule out other causes. But a low FINA less than 0.1, or more specifically, a low excretion fraction of urea less than 21% would suggest also HRS. We have to keep in mind that these labs, the FINA specifically, is not too specific in patients, or too sensitive in patients with diuretics. So in these patients, the excretion fraction of urea is more adequate to use. And we also want to review just here in a moment the indications for albumin in cirrhosis. I don't know if anyone can tell what other indications apart from HRS are the ones that are validated for the use of albumin. If anyone has an idea of in which other context? So I can give you a clue from one other context that I just mentioned. There is the large volume paracentesis. When you do a paracentesis, a therapeutic paracentesis, trying to evacuate more than 5 liters, you should replace the acidic fluid with albumin. And to try to impede that the patient has a RAS activation and a vasoconstriction that could lead to AKI, you give is 6-8 grams of albumin per each liter removed of acidic fluid, and this is in patients with more than 5 liters of acidic fluid removed, but in high-risk patients, you may also give it if you do paracentesis of 3-4 liters. And there's also another context that is the patient with SBP. To reduce the risk of HRS here, the patients need albumin infusion of 1.5 grams per kilogram on day 1, and then 1 gram per kilogram on day 3. So these are the 3 main indications for albumin. In HRS, we can use also other vasoconstrictors. In Europe, is more used the terlipressin that is just recently approved by FDA, and in the States are more used midodrine and octreotide, but these are sometimes used in an ICU context. There's the norepinephrine has demonstrated more efficacy than the combination of midodrine and octreotide, but has to be used in mostly in the ICU. So sometimes it's not used. But these are the main treatments. Yeah.
Thank you, David. We're running very short on time. We're gonna maybe take 3 minutes extra. So I'm just gonna ask very quickly. Let's say the presumed diagnosis in this case was cirrhosis. What are the things you want to do to manage this patient while inpatient? If you can just throw them in the chat, and then we can jump over them quickly. Now that this patient is under your care, what are your next steps? I love it. I see find the etiology, diuretic, and then Sarah said, check the vibes. So this is the teaching point that we had today. This is actually my favorite acronym in all of medicine, which is vibes. And I have that as a dot phrase in the hospitals. I always write dot vibes, where V stands for volume. So you want to start diuretics. A lot of times you start as a mineralocorticoid receptor antagonist and a loop diuretic. Oftentimes with a ratio of 1 to 2.5, just to keep the level of potassium normal. I stands for infection. So you check for SBP and then you rule out other infections. B stands for bleeding. So you want to check if they've had a history of endoscopies. You want to document if there are any varices to prevent that in the future. E is for encephalopathy. So you want to give laxatives to target 3 or 4 bowel movements per day. And then S stands for screening, where you want to screen for malignancy, transplant candidacy, vaccine eligibility, and then goals of care, which is very, very important. And I think in this case, the final diagnosis was decompensated cirrhosis, even though we did not find out the etiology for the cirrhosis in this case, but that might be something that you worked up in a later time. Sorry, Andrew, we don't have the answer for you right now. I just wanted to thank everyone for joining today. We will see you again in another VMR tomorrow.